introduction. So joining us, of course, is Dr. Jennifer Lundine. She's an assistant professor in the Department of Speech and Hearing Science at Ohio State University. She is also a clinical researcher at Nationwide Children's Hospital, where she worked as a clinician on the pediatric rehabilitation unit for 12 years. Her clinical teaching and research interests include cognitive communication disorders associated with acquired brain injury in children and adolescents. So with that said, I'm going to turn this over to you.
Thanks, Amanda. Thanks everyone for joining us. It's really exciting to see where everyone is coming from. And our poll will help give us a little better sense of that, though I'm not even sure in the poll options I sent Amanda, I'm going to cover all the bases. So we'll see. But it is great to have a mix of folks with us here today. And I will try to move through the content. I know the slides are available to you so that we can have time for questions and discussions, which is always one of my favorite parts. So today we will talk about the reasons why hospital to school collaboration for students with brain injury is so important. And we will talk about different strategies that can help promote improved hospital to school transition for students with brain injury. I'm really thankful to Siebert for the invitation to come and share some of these important topics with you today. And hopefully we can keep this communication going after our presentation today. So just some quick disclosures that I get paid by OSU and Nationwide Children's Hospital, and I don't have any non-financial disclosures to report. So Amanda is going to throw up that quick poll just so we can see who we have with us today. I have this term, a community-based clinician, because I'm not really sure what to call folks who are, OTs and PTs and SLPs, but not in a hospital. So, except actually, I guess if you are one of those clinicians in a school, why don't you put yourself in the educator, teacher, school personnel? So if you can answer that question, we'll get a sense of where everyone is professionally. Amanda, I can't tell if.
Yeah.
Okay, perfect.
We've got 94%. So I'm going to go ahead and share this
perfect
so you can see it.
Okay, so I think we had a brain injury survivor on here. So that one isn't captured in the first category. So we have about 25% are hospital-based clinicians, a small number are community-based clinicians, and then a big number, more than half of you are in the schools, which is amazing. So hopefully we can talk about strategies that will be helpful from both of those angles. And then our next poll question.
Yeah, so that one's up there.
So have you worked with a child who has sustained a traumatic brain injury, who was transitioning back into school?
We still have some responses rolling in. Thank you everyone for answering those so quickly. Give it just a couple more seconds. Okay, so here we go.
Okay, so 74% of you have. A small number are unsure, and then about 20% have not yet. So those who have, hopefully you can share some experiences with us about things that have gone well and challenges that you are continuing to face. And for those who haven't, hopefully we can help in the future experiences that you might have. So as we get started today, I want us to focus on our goals and sort of thinking about, what we want for kids or students, children, adolescents that we work with. And we want these children and teens to be their best selves, to have the tools to communicate their hopes and dreams. So as a speech pathologist, that is something that is very important to me, but also to be happy and successful. So that may be, that may include academic success or vocational success or having a family, serving their community. There are lots of different ways that success can look, but we want people to be able to achieve their goals for happiness. And so as we get started, I also want to frame our discussion today because I'm going to talk a lot about children with special healthcare needs, and hopefully you'll see why I am why I'm going to introduce this idea, because this talk is really about students with brain injury. So first, let's focus in on this category of kids, children with special healthcare needs. So there is research out there that estimates this is about 15 to 22% of the population of minors in the United States. So about 20% of kids fall into this category of children with special healthcare needs. And these are individuals who have chronic challenges, whether they're physical, developmental, behavioral, or emotional. And we know that these children specifically, and part of what makes them a part of this category, is that they have increased use of healthcare and other services. So what I'd like to propose is that students with brain injury should also fall into this category of children with special healthcare needs. We know that brain injury is a chronic condition. It's not simply an acute event that you recover from and you're done having a brain injury. And especially when we're talking about individuals who experience a brain injury while their brain is still developing, we still have a lot to learn to understand the potential long-term impacts of that brain injury on the developing brain. And so particularly for individuals who sustain a brain injury when they are young and still developing, they have an entire life left to lead. And again, the chronicity of brain injury is a real potential barrier for those later goal achievements that we talked about on the first few slides. So taking us back to that definition of children with special healthcare needs, we know that that definition includes chronic physical, developmental, behavioral, or emotional conditions. I would argue that brain injury leads to those types of difficulties. We also know that children with special healthcare needs have increased use of services from healthcare and other systems. Again, children with brain injury have those same increased needs for health, medical, rehabilitation, educational, emotional services. So again, here is my argument. Hopefully you are with me, because this is going to form kind of the foundation for the rest of our talk today. That children with brain injury should be considered a part of this group of children with special healthcare needs. So here is a framework that just illustrates the idea of children with complex medical needs, who are sort of a subset within that children with special healthcare needs. But I like this. If you take some time after the talk today to kind of look at the details here, you can see that it focuses on the complex needs that these children and their families experience, that they have chronic conditions, which we've already talked about, that they have higher than normal healthcare usage, and that includes multiple service providers, which again is something that that individuals, children in particular, with brain injury also require. And when we look at children with special healthcare needs, over 30% of them report difficulties, delays, and frustrations in obtaining health and related services. So these are children and families that require increased use of medical services, but yet 30% of them are reporting that they have trouble accessing those services. When we look at just one study of children following brain injury, we see similarly, over 40% of families of kids with brain injury report unmet needs related to speech, education, and physiatry 2 years after brain injury. So again, we're seeing those similar types of issues. Challenges that we know exist for families who have children with special healthcare needs are, again, similar to those who have a child with a brain injury. There are multiple people involved in their child's care. It may be a physical medicine physician and a general pediatrician. It may be a speech pathologist at school and a speech therapist in the hospital or in an outpatient clinic. Same with an OT or a PT. They may see a behavioral specialist or a psychologist outside of school and maybe inside school as well. We know that children with special healthcare needs often have obstacles accessing services within the medical system, but also outside of the medical system, whether they're financial support services or other types of services that are designed to help the family. And unfortunately, we also know that those families who have particular challenges, socioeconomic challenges, language barriers, they consistently report decreased access to various services. So these are not just people who live in rural areas. We have actually done some work that have found that those families that live closest to the hospital in Columbus are actually less likely to return for follow-up visits. So just because you live in a big city doesn't mean all of those barriers are wiped away. The long-term consequences that can be related to poor service access are many. We know that these individuals can have increased acuity of health problems as they enter adulthood. In a little bit of work that's been done in the model TBI studies with adults who have reported having an injury to their brain during childhood, we also know that those studies have shown poor educational access and occupational success later into adulthood. Families who have children with special health care needs report that their children have poorer school and later career functioning or success. And again, unfortunately, these challenges can be increased for minority children and those who have more complex problems. So what about brain injury? For children and adolescents who experience brain injury, we know that comprehensive care is essential. We know that these kids need to be followed or monitored at least into the long term. However, we know that most children with TBI don't receive adequate care over time, and we know that they have lower rates of service utilization and high rates of unmet need at least several years after their injury. In the few studies that have looked at why we see this poor service utilization and higher rates of unmet need, there have been lots of different factors that have been identified that help to contribute to these challenges. So families that are that struggle in their sort of overall family function may also struggle to meet the needs of their children with brain injury. Lack of insurance, limited understanding of the chronic nature of brain injury. So families that don't understand that this is an injury that can impact a child well into the future after their acute recovery. And of course, those individuals who sustain more severe injuries, though it is important to notice that some studies, such as the Fuentes study that I referenced earlier, are even looking at children who have complicated mild injuries as having a high rate of unmet need several years after injury. So medical homes are one way that our medical system has tried to address this care coordination gap for children with special health care needs. And if any of you are involved in a medical home because of a family member or even complex needs that you experience yourself, essentially a medical home is the idea that we have one provider or one place that we can go that helps to coordinate all of our services or many of the services that we need. And the idea is that instead of having to seek out multiple service providers within the medical system, you can have this medical home and they help to connect you to ancillary services like occupational, physical, speech therapy, social work, behavioral health services, and also transition planning as children with special needs are transitioning into adulthood. Now, unfortunately, only 43% of families who have children with special health care needs report being connected to a medical home. And this number is even lower for minority families. Now, there's actually not been research looking at medical homes in children with brain injury. So this is an area that needs some further investigation to see if it might help with care coordination for kids with brain injury. So what are the needs of families who have children with special health care needs and brain injury? Again, remember that I'm kind of lumping our kids with brain injury into this category because here is the children with special health care needs is the area where we have more research to support this, this information. Well, families need interdisciplinary, coordinated, and collaborative care. They need professionals who talk to each other and collaborate with each other. And they need to be a part of that collaboration and communication. And if you are collaborating with other professionals that in a group that also includes the family, that communication needs to be strong, proactive communication. One of my colleagues at Ohio State said this one time, and I was smart enough to write it down. I really like this quote. Buy-in starts with agreement on a shared goal. So if we can all agree that we're working on the same things, that is what will help us buy in to do some of the tough things that need to happen to make and forge these collaborative relationships. So coordination of care should be a priority for all of us, whether you're a family member, a survivor, a school provider, or a medical provider. We know that care coordination demonstrates improved quality care in the medical system, particularly for individuals who have complex medical or chronic medical conditions, and also for underserved populations. And care coordination has long been a professional standard for all allied health practice specialty areas. So this is something that is not new to any of our areas, though sometimes maybe we don't think about it as critically as we do some of the other more discipline specific goals that we might target. So the first thing to remember is that care coordination is within all of our scope of practice. This is a responsibility for all of us, again, regardless of what your role is in helping to care for students with acquired brain injury. So that includes anyone in a school, whether you're a school nurse, a teacher, a therapist, or you are a community-based therapist, a mental health professional, social worker, or a parent who has a child with an acquired brain injury. And just as we think about if I go to a medical specialist, I expect that medical specialist is going to communicate the report to my primary care physician. We should expect the same for any of these other professionals who are working with our children, whether it's teachers communicating with therapists, therapists in a clinic communicating with therapists in the school, and so on. So as we think about the ecosystems that children operate in or that children live in, for kids who don't have brain injury or don't have special healthcare needs, primarily we have children in their family unit and children operating at school. We'll consider this sort of a pre-pandemic and a post-pandemic, hopefully, world, because now maybe this bubble is really just the home and family. But nonetheless, we used to have kids that would go to school. And so we would have these two crucial ecosystems where children operated. But for children with special healthcare needs and inclusive of children with brain injury, we also have this third ecosystem that is incorporated into a family's life, and that's the medical system. So how does that work for families? Well, unfortunately, not very well at the current time. So the research that has been done looking at how families are engaging in this complicated triple ecosystem, families report that they have limited knowledge about educational services that can support the child upon returning to school. So they don't have a great understanding of the educational implications of medical treatment. So how does this brain injury impact their child when they return to school? What are the long-term downstream effects of this injury? If a child is injured in kindergarten, how might that show up in a child's educational performance when they're in middle school or high school, possibly? And families rely very heavily on school and medical professionals to, one, understand their child and understand the impacts of their medical condition, but also to share information. So families don't want to be that conduit. They expect that schools and medical professionals are sharing information between each other without using the family. So what do schools report? Well, they feel that a lot of responsibility sort of unfairly falls on their shoulder. And I think that in many respects, this is a fair critique of the current system, because this is where kids are spending most of their time. And schools are responsible for, making sure that the child is doing well in the academic environment, but they may not have all of the pieces that they need to help put this puzzle together. Schools report that they don't understand brain injury sufficiently. They don't understand the impact of the diagnosis or the treatment, that child might require, and how it can impact academic outcomes and socialization. So thinking about even peer interactions and social communication as a very important element for young people. They have a poor understanding of the services that they might be able to provide, even strategies that might be simple to implement. They are not trained in understanding how those strategies might be implemented and for which students they might be most appropriate. And they report that they don't receive consistent training on brain injury or other complex medical needs. And similarly, medical systems also feel sort of out of the loop. They have less evidence related to perspectives outside of themselves. And they admit this themselves. They don't have good practices for collaborating outside of the hospital. And we'll talk about some of those potential barriers in a few minutes. And they report a lack of understanding regarding school policies and services. And anyone here that works in a school, I'm sure, could talk about times where they've received a prescription from a physician saying that, Johnny Smith is prescribed an IEP or physical therapy at school, which we know is not the way it works, but I'm sure that most educators have seen that. And again, that is due to a lack of understanding from medical professionals as to how services are provided in the school environment. So then there is this brilliant idea that exists in some places for school liaisons or educational consultants. And this is something that is commonly brought up, that parents are interested, educators and healthcare providers are also interested in this idea. And there are some places that do have school liaisons. So at Nationwide Children's Hospital, we're a very large children's hospital. We have, I believe, 2 of these individuals who are actually employed by the hospital, and they support our children with cancer diagnoses. So they are able to follow the students after they leave the hospital and help with IEP meetings and going and talking to peers and teachers. But that's 2 at our gigantic hospital. Our rehabilitation unit, we do have a teacher, but once students leave our unit, the teacher does not have a role in helping to transition that child to attending IEP meetings. Once they have left our floor, we sort of let go of them for all intents and purposes. So the idea of an educational liaison is a pretty amazing, but also very rare individual. The idea of an educational liaison or consultant is ensuring that all of these key players have access to relevant information, making sure that the school understands the impact of the medical diagnosis, but also that the medical team understands what the school is able to provide and how they might best provide that for the student, and keeping the wishes and the goals of the family included as part of that communication. The educational consultant helps to make sure that key stakeholders are included in all parts of the return to school and reintegration process, and they can also offer training and education as needed. So here is a model of what that might look like. This is a model that was designed for students with cancer specifically. So think about it a little more broadly as we think about children with special healthcare needs or children with brain injury. These bidirectional arrows are reinforcing the idea of bidirectional communication. So essentially everyone is talking with everyone else. And this is a really beautiful model, which I would argue is about as common as a flying unicorn. So maybe a little more common. I mean, these people do exist, but they're very rare. So we need to think about how can we achieve collaboration and communication to help students transition from medical to educational settings without this magic unicorn. Or perhaps this is something you have, and you can try to promote that person into doing more things with more students for sure. And that is amazing. So certainly this is something that we can all strive for. But I would also argue that this is something that we can do, whatever your role is. I would bet that there is something that you can do to help promote this collaboration and communication, to help improve transitions for our students who experience a brain injury. So we know that families are navigating multiple systems. They are navigating the schools for their child, the medical system, insurance, and also different community resources. So are there social services that their child might benefit from, or transportation providers who can help to get them from one appointment to another, or that they need to try to navigate to get from one appointment to another. So there are multiple systems that families have to navigate in order to provide the best care for their child. When we think about schools and children with special health care needs, approximately 20% of children who enter schools have a special health care need. So this is a pretty high percentage of students who are in all of our schools. And also important to think about the fact that many of these students are mild or not yet diagnosed. So they are going to be those students who look okay. Maybe they're just a little bit behind their peers. They're not quite keeping up, or they're not quite as attentive as their other peers. But again, many of them don't have a specific diagnosis that the school is aware of. There are also inconsistencies in the perceived need for support. So are there services that the school could provide that could help that child attend a little better in the classroom and maybe cut down on the behavioral outbursts that he or she might experience or might have during group time, for example. But we also know that there is lower service provision for these students specifically, especially those who have subtle or undiagnosed difficulties. We also know that students with brain injury are under-identified in our schools. Now, there is a very low percentage of students who are identified with a brain injury when we think about the actual number of young people who sustain a brain injury in the United States every year. So again, thinking about the model of the ecosystems, we can think about how we might be able to impact these challenges that I just shared, that so many students that are entering schools have undiagnosed or mild difficulties that would likely benefit from some type of service provision. And the first thing we need to think about is how to better identify those students in order to provide those services. We know that schools are the major place where young people with a brain injury are receiving rehabilitation. So there are estimates that only 4% of kids who sustain a traumatic brain injury are admitted to an inpatient rehabilitation unit. We know that children who are admitted to a rehabilitation unit are more likely to be connected to ancillary services like OT, PT, speech, and also to receive, to have their school be notified that they sustained a traumatic brain injury. But that leaves an awful lot of kids who don't have the benefit of those additional connections immediately following their injury. But we also know that those kids are going to go somewhere, and the place that they're going to go is into our school system. We also know that one of the main predictors of good outcomes for children with brain injury, and also for children with special health care needs, is recognizing those possible difficulties and proactively establishing a plan to deal with them to help that student be successful. If a child or an adolescent is admitted to the hospital or to inpatient rehab, we know that they're heading back to school during a time of critical recovery, during a critical recovery window, whether they're admitted to the hospital or whether they've just sustained a concussion. They take 2 days off and then are back to school. We know that this is a critical time. We also know that if we can prevent academic and social failures, we are more likely to lessen behavioral challenges. Based on the mechanisms of pediatric brain injury, many of these children do experience some behavioral challenges, but we see that those behavioral challenges increase when the student is not feeling successful at school and they're not feeling socially connected to their peers. So if we can try to prevent those problems first, then likely we can prevent those behavioral, or we have a better chance of preventing or lessening those behavioral challenges. And the way we can start to think about that is by improving the communication that we've already alluded to today. So I see that there are a couple questions in there, Amanda. I don't know if this is a good time to tackle one or two. Let me look at our time.
Sure, I think we can fit in a couple.
Okay.
So some of them are coming from Clifford. One of the questions is kind of back from the beginning of your talk. I want to know where the medical homes exist.
Where do the medical homes exist? I'm not sure how to answer that question, Clifford. I mean, they exist in large pediatric medical centers, are probably more likely to have them. Larger adult medical systems are also more likely to have them for individuals who have complex medical conditions. But I don't know that I can give you a lot more specifics on that one. You can feel free to email me afterwards and I could try to answer that a little bit better.
Okay. And then I have a comment from Carla that said one report stated that 93% of children with brain injuries go undiagnosed and unrecognized. Not sure which report that is, but there's been lots of supporting comments of that nature along the comments in chat as well.
Absolutely. Some of the important work that's been done by the Siebert group that has looked at how these kids are identified in school has identified, how few we actually are labeling as traumatic brain injury for special education purposes. Some of the work that the CDC has done has identified when we look at the numbers of students or young people who visit the hospital with a traumatic brain injury, which is where most of our prevalence data comes from. Unfortunately, some studies that have looked at major pediatric medical systems like Children's Hospital of Philadelphia identify that 75% of children actually enter the medical system through their primary care providers or urgent care, which means that they're not even captured in that data from the CDC looking at the incidence and prevalence of traumatic brain injury in kids. So again, I think this is a much larger problem than the numbers that we have are allowing us to look at. So I was recently talking to a school psychologist who's been working for 20 years, and she said in her 20 years, she has evaluated 2 students that have identified that they've had a traumatic brain injury, which I find, and she finds, really hard to believe that, in a very large school system in 20 years, she's only encountered 2 students. But I think this goes to the idea that these can be very invisible injuries and a challenge for all of us who are trying to help these kids for sure. So let's transition back into moving on, and then we can come back at the end. So maybe if you could throw into the chat what you think some challenges are that we could face thinking about your position and where you are professionally, or if you have a child with a brain injury or you are a survivor, what are some challenges that we might face in coordinating services? Just throw a couple of those ideas into the chat and I'll check them out.
And usually that just takes a couple of minutes.
Okay.
a couple
minutes. Okay.
Well, it gets going. First one's from Kristen.
Okay, I see that lack of pediatric resources. That's a good one for sure.
I'm sure folks are still typing.
I know. So while you're typing, you can feel free to keep going. I'm going to, I'm surprised that this wasn't the first one in there, because usually I feel like this is the first thing I hear is time, that we don't have time. You know, I don't have time to try to figure out who the school therapist is. If I'm a school therapist, I don't know who the hospital therapist is. It's hard to connect with the teacher. I don't even know who the students' teachers are. So time is definitely a challenge that we have to talk about, we have to address when we think about coordinating services. And here are a couple other challenges that we'll touch on, and then get back to some of the comments, because I'm sure you're coming up with lots, and probably we could do an entire talk on the challenges for coordination, but hopefully we'll be able to move into a positive direction about how we can combat some of these challenges too. So first, let's think about and talk a little bit about the misunderstandings that exist between scope of practice between schools and non-school providers, and the communication challenges as well. So really quickly, I won't go through all these bullet points. Understanding the differences between school-based providers and what I'm using the term medically based services in the green box, and really that just means non-school providers. So community-based services or medically based services, but just the idea that our scope of practice and what makes a child eligible for services in these different environments is different. And sometimes folks in one area don't necessarily understand those differences in the other area. So for example, school-based services, the therapy plan is determined by the IEP team, and they have to be addressing a need that is academically relevant to the child, something that is affecting their ability to access the curriculum, which is different than medically based services. I could see a student, I could see a young person for any type, or for lots of different things in my outpatient clinic at Nationwide Children's Hospital that a school therapist might not be able to justify in the school environment. The other important thing to remember is that discontinuation of therapy services in one setting does not mean that therapy services have to be discontinued in the other setting. So just because the school therapist discontinues services, it doesn't mean that you can't continue to receive services from a community-based or medically based service provider. Again, there are differences based on what justifies our ability to treat in those different settings. And there are also misconceptions that exist between those two groups. Sometimes parents don't support sharing of information between settings, or they may not be helping to facilitate that. So if I am a school-based provider, I may have no idea that this student receives services in an outpatient clinic. And maybe that's because the parents have not told me that. Perhaps I've asked and they have not told me the truth. You know, there are lots of reasons that parents might not choose to share that information, or that it has just not come up. Another misconception is that school interventions are so focused on needs in the academic setting that it won't relate to what a community-based therapist is doing. So why would we even talk? Because our goals are going to be so wildly different. Another common misconception is sort of disrespect for the other individuals in the different settings. So underestimating the expertise of school-based personnel, or school-based personnel underestimating the understanding of medically based providers, that none of them understand how school services work. And again, as we talked about earlier, it may be true that we do have a lack of understanding, but it doesn't mean that that's not something that we can't foster ourselves. When we think about communication challenges, so obviously this is important to me as a speech therapist. School-based and outpatient providers often are treating the same area and the same concerns that a child has. But unfortunately, communication can be limited because we have these misconceptions that exist. Sometimes school-based personnel have very limited parent interactions. It's possible that you are not talking with the parent except at an IEP meeting, whereas a community-based therapist might see the parent because they bring the child to therapy every week. As mentioned before, providers in either setting may not be aware of the other services that their student is receiving. Surely connecting with those service providers can be a challenge. How do you find the right therapist? As a speech therapist in a hospital, I'm not at my desk, but speech therapists at schools aren't at their desk either. So how do you connect with that person? And that is always a challenge. How do you identify who that person is in a large system, and how do you possibly connect to them? And then the challenges with privacy laws as well. So I'm not going to talk about this in a lot of detail, but understanding that there are different privacy laws that are governing medical information versus educational information. But it's important to know that these are challenges that can be overcome. So is there a way that we can create a simpler consent form that will allow communication between sites or between individuals? How can we facilitate that? At our hospital, we've worked at trying to create one common consent form that our major school district worked with us on creating, so that families could sign it once and it could apply to all providers within nationwide children's healthcare system, for example. So not an easy task, but something that can be addressed. As we mentioned previously, teachers and educators are often unfamiliar with some of the challenges that can come with chronic conditions, and that includes brain injury, of course. Families may be a part of that challenging communication as well. They may not want the school to know that their child had a brain injury because they don't want their child to be labeled as different. As a child with brain injury is looking better after that acute recovery, they may not want to pass on that information to middle school or high school, for example, even though it's possible that difficulties could arise as that student enters higher grades. So I would like to empower you, whatever your role is. You may be the right person to fill that space in that complex ecosystem that children with brain injury are trying to navigate, and those families are trying to navigate as well. Many professionals can help fill this role, and working together, we can even do a better job of trying to bridge this gap. Based on whatever understanding you are, wherever your expertise lies, whether it's the educational system, the medical system, the family system, and how to support these children. Consider your own knowledge base, your experience, and how that can help you fill this role to serve as the connector for families who have children with a brain injury. We can't wait for that perfect flying unicorn, the educational consultant or the school liaison, because as my hospital has tried to hire numerous people in lots of different clinic areas and it has been denied year after year after year, we have learned that we have to figure out how to solve this problem without waiting for that perfect person to arrive. So how can you contribute to helping to improve the transitions and the continued communication and collaboration for students who experience a brain injury? So why you? I would argue, depending on your role, you may have the best relationship with a family and you may have a more direct relationship with them than they have with other medical or educational providers. If you have a good relationship with a family, of a child with a brain injury, then start having this conversation. How are things going? Are they accessing care? Where are they having trouble? And use that information, use the knowledge that you have about brain injury and how it can impact a family, how it can impact a child at school, and promote how you can use that information to educate other people, to help and grow these collaborative relationships. Again, depending on where you are in the continuum, leverage the relationships that you have to educate individuals, whether it's school professionals about the effects of brain injury, or whether it's about medical professionals, educating medical professionals about how services are provided in the school setting, or families about the long-term potential impacts of brain injury. Leverage those relationships to begin to build these collaborative relationships. And taking us back to that ultimate goal that I think we all have is, how can we better educate and advocate for these students with parents at school, and also, though it's not on this bullet point, and within the medical system, because that is, they have things to learn too, and they need to be a part of this collaborative relationship. Because in order to improve outcomes for students who have a brain injury, we have to build and foster these relationships between schools, other healthcare providers, and of course, I should have the family on here as well. So how do we do this? I know our time is running short and I do want to leave time for questions. So some practical ways to think about how to begin serving as this person. Ask questions. As I mentioned a minute ago, ask questions of the family if you are a person who has a direct relationship with them. Where are you struggling? What barriers are you facing? And how might I help connect to other people to help release or reduce those barriers that you're experiencing? Making connections, reaching out to folks within those other ecosystems, whether if you are an educator, reaching out to people at the hospital or a clinic or a researcher. Even if you are in a small town that doesn't have a large children's hospital, there are still resources for you. Reach out to the closest children's hospital. Make those connections and try to foster new relationships so that you can try to be one of those people who pushes this communication and collaboration. If you're in a school, work in a child's classroom, see how they are functioning in a classroom. Once you know that they have had a brain injury, use those important contexts to try to establish, are they having subtle difficulties that might be addressed by some kind of service provision in the schools. And then collaborate with other people, whether it's teachers, outside providers, or other appropriate service providers. Share goals. Things that we're working on in an outpatient clinic are definitely going to be relevant for that child at school. If I'm working on memory strategies in an outpatient clinic, the most important place for the child to generalize those goals is in their school setting. Likewise, if I'm teaching strategies in a school setting, I want the outpatient therapist to know that so that we're teaching the same types of things. So sharing progress, sharing goals, and sharing a plan of care is essential. This is not easy. This is certainly challenging. If it was easy, we wouldn't be having this discussion because it would already be done. But it is worth it, and we can impact for the better the outcomes that children with brain injury experience if we can better coordinate their care. We can leverage the benefits of school-based services and community-based services so that they're working together and not duplicatively. There's no reason for the same things to be happening in two different places. Instead, we should work together to augment the services that we're providing. The child can achieve goals faster. It reduces the financial burden on families. They don't have to be attending services once those goals are achieved, or maybe they can reduce services in one area. It makes the children feel better about themselves. They are, again, experiencing more success, and ultimately we'll see better outcomes for those kids. All right, that is all I have for you. So I am excited to open up for some questions or conversation. Thank you.
Thank you. Jana had a question, said, how do we lobby to get funding for transition specialists to facilitate hospital to school reentry? Because I want to do that job.
Yeah, I don't have a good answer for you. As I mentioned, my hospital has tried to do that in all kinds of areas for literally years, and we have not been successful. So I don't know. That's why I think we have to think about other ways to achieve this goal, because I mean, obviously we know school funding is really tight, and frankly, hospitals where you might think there is more money, it's hard to justify those service providers because they don't generate revenue. And even if a hospital is a nonprofit, there are lots of services that don't generate revenue, and they're not necessarily looking to create another one. So I don't know that that's going to be the answer that is going to really solve this problem. That's my own personal hunch. I think, again, if we can be creative about ways to make this part of everyone's job, and I know no one needs more parts to their job, but if we all are doing a little piece of this, then maybe we can really address this issue to help these students.
Kylie is wondering if you have any advice for a mother in a rural community that has been told her daughter's ABI condition is what it is. Good luck. They've been to UW and St. Luke's in Spokane, and according to the mother, they both told her this.
That's really terrible. I'm sort of speechless. It's not shocking, I guess. I have heard that from families as well. I think the family, so I'm not clear if the hospital also told the family that. And yes, a brain injury is what it is, but it doesn't mean that there's nothing we can do. I mean, brain injury is treatable. There are strategies we can employ. And that's what I think this family needs to hear. And then there needs to be education provided to the school about how they might be able to address any deficits that this child is experiencing. I don't know, obviously, anything about what kind of challenges that child has, but it is not like a hopeless case by any means. So yes, the injury is what it is, but it doesn't mean that where that child is where she is. There is, always room for improvement and strategies. There is plenty of evidence to say that strategies can be helpful even for individuals with severe impairment. So they need to keep pushing and find a person who can help advocate for them and try to educate the school. And in worst case scenario, and I mean, this truly worst case scenario, like after all of those, avenues have been tried, certainly there are legal recourses that a family can take. And usually there are advocacy services that can help a family. Though again, I would try that last. After first trying to establish some collaboration and communication in a positive way, to try to promote some services for that student.
Thank you. Looks like there were a number of comments along that in the chat.
Okay, I can open that up.
So I'm going to open that up as well. And Melissa, feel free to chime in on that one if you wish. I saw that you had a comment in there, so you're welcome to come join us.
I'll jump in and read the last comment that as a hospital teacher, there are so many students coming through the hospital system, it's difficult to follow up with every family and student. And this hospital teacher agrees that the more people are involved in advocating for the student, the better, rather than hoping to hire an educational liaison. And in my experience, I think that is true. And just like teachers in schools, hospital teachers are overwhelmed as well, because there are so many students that could benefit from some extra transition services. And unfortunately, they don't have the capacity to do all of that either. So there's work to do. There's certainly work to do.
Taylor Wood just made a comment that the Brain Injury Alliance of Washington can help advocate and provide resources for the mom.
Great.
So perhaps we can make some connections post this. My email is in chat way back at the beginning. So I will talk back in here. So if you guys are looking for those kinds of collaborations, you're welcome to email us and we will help connect you as best as we can.
Thank you. Tammy mentioned too that in the state of Pennsylvania and also the state of Colorado, there is a state funded program called Brain Steps, which is a state-funded program that is accessible or available to any student with an acquired brain injury. So not just traumatic, but any kind of acquired brain injury. But that is unique to Pennsylvania and Colorado. I know Oregon has a similar. I don't know. Can I say that it's a statewide program?
It is. It's statewide.
Okay.
It's funded solely through the Department of Ed.
Okay, thanks, Melissa. And Nebraska, I believe, also has a statewide program, but these are, these are not available in every state, and most states are doing different things district to district. So some districts have really great support, and some, don't. And even large school districts who may have more students with traumatic brain injury, some are better equipped to deal with them than others. So, this is a problem that, is definitely nationwide. I would love to hear from our international friends to hear, how this is dealt with in Australia or the UK, where I know there are really strong research groups, but I'm not as familiar with the services that are provided. So I'd love to collaborate with you and come to Australia or the UK.
Okay,
as soon as we can.
Jessica made a comment that the ARC of Washington provides advocates or families who are struggling with schools, providing services and supports around IEPs and 504s.
That's great.
Yeah. Tanya, thank you so much for joining us. And I do see we are right at 4 o'clock. So yeah. If there are further questions or looking for some collaboration or ideas, please feel free to email us. Again, my email is pereza@cbrt.org. And in your handouts on that final slide, you should see Jennifer Lundine's contact their information as well. So thank you all so much for joining us. We were excited to have you.
Thank you so much.
We'll see you at the next one.
Okay, thanks so much, everybody.
Bye.